As you heard, I'm a law professor, sociologist. I'm also a professor in Africana Studies, and I'm going to address this question focusing primarily on racial health disparities from more of a legal, sociological, and especially political point of view. Science operates in the context of politics, so that's the part that I want to talk about. In 2007 in Chicago, there was published a very striking study that found that Black women in Chicago, although in Chicago they had a lower incidence of breast cancer than white women, died at twice the rate as white women. And in this Chicago Magazine article, they asked the question we've been asking, why and what must be done about it? And as we've heard, there's many ways to think about why would it be that Black women in Chicago die at twice the rate from breast cancer as white women. One might be it has to do with something in the environment. Another might be that there's something innately that predisposes Black women to death from breast cancer. And one of the clues that these researchers looked at was how that gap developed over the 20 years prior to the study. So in 1980, Black women and white women died from breast cancer at exactly the same rate, and the gap occurred over the next 20 years with not Black women's death rate going up, it stayed the same. It was that white women's death rate was cut in half. And the researchers concluded that it had to be, or most likely had to be, something to do with the advances in breast cancer detection and treatment over those 20 years. As Dr. Whitman, who was shown on the first slide, said to me when I interviewed him about it, white women got all the advantages of the advances in breast cancer research, and Black women in Chicago got absolutely no advantage from it. Now, despite findings like this, there is a persistent view that the reason why Black people suffer more from disease in the United States is because there's something innately in their bodies that predisposes them to disease and death from disease. And so I want to talk a little bit about the very concept of race and Black race and where that comes from. We know that the idea that human beings are divided into races originates around the 17th century and is really, really reinforced during the 18th century Enlightenment period, with European typologists creating hierarchies of human beings after the point when Europeans began to conquer other peoples and enslave them. And so we can think of race as a way of classifying people in order to justify enslavement and conquest. We can also think of science as being highly influenced by the division of human beings into race. It has been a way that scientists since this time have classified human beings in order to study them. Many people thinking you have to classify human beings by race in order to study them, which shows how influential this approach to science and humanity was. That idea transferred to the United States with naturalists in the United States like Thomas Jefferson, continuing to believe that there were natural distinctions between Blacks and whites and using those distinctions as a justification for the political inequality between Blacks and whites. So Jefferson observed differences that he said came from nature, and he explained the reason why Black people could not participate equally in the United States with whites was because of those innate biological differences. That idea was absolutely essential to the justification for slavery in the United States, and it was promoted by doctors and medical researchers like Samuel Cartwright, a very prominent researcher who got his education at University of Pennsylvania Medical School and was commissioned in Louisiana to investigate the peculiar diseases of Black people. The idea that people of different races have peculiar diseases and experience common diseases differently. His major theory was that Black people had lower lung capacity than whites and had to be forced to work in order to be healthy. So according to his theory, Black people were better off enslaved because that was the only way they could be healthy. He also discovered a disease he called drapetomania, which was the mental illness that Black people who escaped plantations had, because of course they must be crazy if to leave enslavement, which was actually good for them. Now, that idea that Black people are categorically different than white people in terms of their experience of disease has continued in medical practice in the United States. And so doctors are taught to treat patients according to race, but not just to use race as part of their diagnosis. In some respects, race is embedded within technology so that automatically a Black patient is seen as different from a white patient, regardless of the symptoms or other clinical indications. And one example is the glomerular filtration rate. In this blood test, you can see that there is an automatic different reading for a Black patient than a patient of any other race. In other words, this is reading a protein in the blood. I don't have time to go into the details of it, but the same amount of protein in the blood produces a different reading if the patient is Black than if the patient is white. The doctor is looking at this patient, and if the doctor believes the patient is Black, it's one reading. If the doctor believes the patient is any other race, it produces a different reading. That is an automatic categorical distinction, which I understand is based on an old theory that Black people have greater muscle mass as a race than white people, regardless of what the scrawny little Black patient in front of the doctor. Okay. Samuel Cartwright's perfection of a spirometer to measure lung capacity in Blacks compared to whites has continued to the present day in the form of automatic correction of lung capacity for assuming racial differences in some versions of the spirometer. Again, the same amount, the same reading is different for a Black patient than a patient of other races based on the assumption that Black people naturally have lower lung capacity. Now, most doctors will say, well, we use race as a proxy for other factors that are more important because it's a helpful tool, and this benefits Black patients. But there are lots of examples of how this mistreats Black patients, and I'll just have time to point to one especially horrifying example, and that is the undertreatment of Black patients for pain. Numerous studies have found that Black patients get less pain medication or no pain medication for the exact same injuries that white patients have, like a long bone fracture that you can see on an X-ray. A very disturbing study that came out a couple years ago was the difference in analgesic opioids given to children who are in severe pain from appendicitis. Look at the difference. Now, and interestingly, this relates to another health disparity we're seeing today, which is the very high rate of opioid addiction among white people. We saw lots of statistics where Blacks are faring worse. In terms of opioid addiction and deaths from overdoses from heroin and opioids, white people their rates are skyrocketing. In fact, you may have heard that white people are the only group in the United States whose death rate is increasing. And it's largely because of suicides and opioid and heroin overdoses, which we can trace in part to doctors not wanting to prescribe this kind of pain relief to Black patients, but being perfectly fine prescribing it to their white patients. Because of why? Well, an interesting study last year from University of Virginia linked this undertreatment of Black patients for pain to stereotypes about biological differences between whites and Blacks, including beliefs like Black people have thicker skin than white people, Black people's nerve endings are less sensitive than white people's. This is what residents who are treating patients at University of Virginia found, but there's evidence that this is widespread among doctors in the United States. Now, when the map of the human genome was unveiled in 2000, there was a lot of expectation that research would be done without grouping people by race, because everyone involved announced that the human genome showed no evidence of racial divisions at the genetic level. Clinton saying that human beings, regardless of race, are more than 99.9% the same. We heard from Sarah, just if you take the continent of Africa, the amount of genetic diversity that exists in what is supposed to be a separate race of people, but also that the diversity around the world cannot be grouped into what we think of as races. But what happened instead, as Nicholas Wade announced in the New York Times, was that scientists began to look for genetic differences between human races and to explain health disparities based on genetic differences in race. I published a book in 2011 called Fatal Invention: How Science, Politics, and Big Business Recreate Race in the 21st Century, where I documented this increase in interest in gene-based variation between races. And I argued that there was a new biopolitics to this that very much mirrored the old biopolitics of race and science, which was that scientists were defining race as a genetic grouping, using genetic explanations for racial inequalities in a supposedly post-racial society. So genetic difference comes in handy when you're in a society where you can see lots of racial inequality, but we're not supposed to have racial inequality anymore in the United States. What causes it then? Innate differences, many would say, between the races. And then biotech and pharmaceutical companies are producing race-specific biological remedies for these inequalities. Nicholas Wade wrote a book where he argues that there are three principal races: Blacks, whites, and Asians, and that they evolved separately, and not only to have physical differences, but also differences in social values and social institutions. I won't belabor that, but I want to point out that he provided a genetic definition of race based on this theory of separate evolution of Black people, white people, and Asian people. I'm not sure exactly when that happened or what prevented people on the vast continent of Europe and Asia, it's one landmass, from interacting, or where the line separated the two, the wall that existed that didn't allow any interaction. But he doesn't explain that, but that's the theory. Now, that theory shows up in a lot of scientific journals as well, that races are population clusters based on genetic differences due to evolutionary pressure. And another study in 2013 found that after the mapping of the human genome, there was a huge increase in studies that treat race as a biological category. These are studies that address the relationship between race and genomics in peer-reviewed scientific journals. There was also been a continuance of, this has happened for centuries, but a continuance of the idea that health disparities, like the disparity in infant mortality, preterm births, breast cancer, et cetera, are caused by some innate factor that predisposes Black people to these negative consequences. And this is just one example of a hypothesis that Black race, independent of other factors, increases the risk of extreme preterm births and its frequency of recurrence, hypothesizing that it would be possible to control for all the other factors that could possibly explain why Black women have a higher incidence of preterm birth. And so what the researchers do is control for a few factors and then conclude that there is a probable genetic well, they say it in very vague terms, but they conclude basically that genes are the explanation for these disparities in preterm birth, and the New York Times reports it as if they found this, when in fact they did not find it because they did not control for the other possible reasons why there are these disparities. These kinds of studies have a lot of confusion to them, which I think it's important for institutions like the National Institutes of Health to clear up. One is the confusion between a genetic and socio-political category. When these studies use African Americans, what are they talking about? Are they talking about people with pure African ancestry? How much African ancestry? Is somebody who has mostly European ancestry, but one drop of African ancestry, part of the Black race? Why are they the Black race? Well, clearly because of a socio-political decision that they're part of the Black race. Criteria, how do you know who belongs to each race? Some use self-identified race, some use the OMB directive that Karen referred to, which is the census category. It's a social category, but they use it as if it's a biological category. Some are making up biological ancestry informative marker basis for a racial category. Some use things like Spanish last name as an indicator of a biological category, and others use appearance. They just look at the person and guess what race they are, or they use stereotypes about them. It also, as I mentioned with the other study, confuses genetics with unmeasured factors. You can't conclude that genes are any amount of contribution. You don't know if you haven't control for the other factors, and often researchers leave out very important factors, including the experience of discrimination. As an op-ed piece said a couple of weeks ago in the New York Times, we're sick of racism, literally. And this is a new field of research that hasn't been adequately brought into studies that are concluding that there are genetic reasons for health inequities. Recently, this idea that the reason for differences in disease burden among African Americans is because of genes has been adopted by the Food and Drug Administration in its approval of the first race-specific drug, which, by the way, was not developed using any genetic research or any reference to race. For commercial reasons, it ended up being a drug for Black people, and the FDA assumed that race could be used as a surrogate for genetic markers. Now, what I've been talking about has also faced opposition or contestation for 100 years by researchers like W.B. Du Bois, who synthesized a sociological and an epidemiological approach. And he pointed out that many of the diseases like consumption, tuberculosis, that were attributed as innately part of Black people's biology were experienced by other groups like the Irish. And he says, but when they were not popular, at the time when the Irish were considered inferior to the British, the English, they also suffered from these diseases. So he recognizes that there are political and social reasons for these gaps. In my book, Fatal Invention, I argue that we should be studying how racism is embodied and make the distinction between race as a biological category that naturally produces these disparities as opposed to a political category that has biological consequences. And here at Penn, I founded a program on race, science, and society where we are looking at transformative and interdisciplinary approaches to the role of race in scientific research. that aims at promoting social justice and dispelling the myth that race is a natural division of human beings. And in conclusion, I argue that we should be addressing the social and political institutional reasons for health inequities that are supported by a biological theory of race, not incorporating a biological theory of race to explain what are social differences. And in the end, a more just society. If we want to end health disparities based on race in the United States, the best way, and there's lots of evidence for that, to do that would to have a more just society, a more racially equal society. That would produce a healthier one for everybody in this country. Thank you.